Dear colleagues, thank you very much for inviting me here and to give a chance to talk in such a meeting. I'd like to talk about CTO toolkits, and what we need to have essentially is, of course, sheath and guiding catheters. Of course, we need them for all procedures, but we should have to make sure that we need to have all length of sheath and all size of sheath, like 7 French, 8 French long sheath, and also we need to have 7 French guiding catheter, which all type of guiding catheters, not only 1 or 2 type. Of course, we need to have CTO guidewires, microcatheters, antegrade dissection reentry equipment, snares, very important. Externalization wire is also extremely important if you do retrograde case, and we need to have some additional tools I will mention and some complication management tools. In terms of guide wires, we have actually lots of guide wires for CTO. Asahi families, I think, has most of them. We have Fielder FC, XT, XTA, XTR, and Confianza Pro and 12. We have Miracle Browse. It's a little old-fashioned, but I still use them very successfully. We have Scion and Gaia series. Also, we need to have Pilot 50 and 200. And also, we have specialized wire like Stingray wire, very stiff one. And also, we should have super stiff wires in our lab, which is Confianza 20 anterior or Astato, which is originally peripheral wire, 20 and 30 gram. In terms of externalization wires, we have to have specific externalization wire. At the moment, we have RG350 Vipro wire advance in the market. And we have several microcatheters. We don't have to have them, have all of them, but at least 1 or 2 microcatheter you should use and you should be familiar. Corsair has many advantages of the others actually. It has excellent crossability through the collateral channel, and there is no need to channel dilatation in this catheter, and it gives us better support for tortuous channel. And also we can use Corsair in epicardial channel as well, and it's help us for retrograde technique to have better support for inserting the wire. Another microcatheter which I love a lot is Fine Cross. Fine Cross also as much as good like Corsair, because it has also good advantage. Fine Cross is thinner than Corsair. Sometimes you cannot insert Corsair, but you can insert easily Fine Cross. So we should definitely have Fine Cross too. Turnpike catheter, very similar to Corsair, and they have a gold and LP now. And also there is a deflectable catheter like Venture catheter. It's deflectable. It has deflectable tip. It's extremely helpful when you needed that. You may need in 1 or 2 times in a year, but it's very nice to have in the lab. You can talk on the tip. It's microcatheter actually, over the wire system. And also, very important to have double lumen catheter. This double lumen catheter, there are 3 at the moment in the market. Twin Pass, for example, here. There are 2 lumen. One is monorail, and the other is over-the-wire system. This wire works like monorail. It comes from here, but this wire comes from the end. So this is over-the-wire system. It's extremely helpful. I will show you some examples. And there is another catheter, Draw Cross, belongs to Terumo. And another one, Enhancer RX, belongs to IMDS company. This is also a new one. This is the third one, the Lumen catheter we have in the market. And also, I'd like to mention the Straub Technique Stingray, and my colleague Julian will talk about this after me. And Crossbows, yeah, they work together. Also, we need to have some supportive guiding, extension guiding, like Godzilla or Godliner. We use them for have a better support and to have isolation of the side branch, which is also very helpful for retrograde approach. And we have Tornus catheter. This is important if we cannot insert anything rather than wire. If we cannot insert balloon, then we can use Tornus catheter. It goes nicely. But we need this Tornus catheter very rarely these days because we have such a nice balloons now. But still, we may need to use it. This is Tornus. There are two types, 2.1 French and 2.6 French. And snares, yes, we need to have big snares to trap our wire when we work retrogradely. I will show you two examples. And this is, of course, we have to ready for any complications such as rupture. For example, for collateral rupture could be very serious and catastrophic. To manage this, we need to have graft stand and coils and some glue. And I don't want to talk about the wires, but I like to mention Gaia again because this is a new wire and really excellent wire. I think it's very helpful in many cases to do antegrade, and also in retrograde case. There are three types. Gaia first is 0.15 gram, Gaia second 3.5 gram, and Gaia third 4.5 gram, the tip load. How can we use it? It's a little different than the other wire because if you push it hard, it's just deflect. If the wires touch something stiff or calcium, it just deflect. So we know that if the tip is deflected, it means we have to change direction of the wire. So what we do, we try to insert to Gaia. If we have some deflection, we just change the direction and try to find a soft tissue for penetrate. That's the philosophy of the wire. If we push too much and the wire is deflected, it goes easily subintima and make a dissection. We have to aware of that. I'd like to show you one example. This is Circ CTO. It's not that long. When we use Gaia, we just deflect our, we just a little push. We cannot drill this wire. It's different than other wires. We have to very slowly, we have to slowly torque on it, and then we have to push gently. For example, here we are going down, and now I change my direction a little bit, and another direction, and another direction. There is no deflection, but it goes smoothly. And at the end, I am in the distal lumen, and this is after stent implantation. So I will give you some practical examples. Most of the time we can use either Corsair or fine cross, but in certain situations, for example, if we deal with proximal circ, as you see here, there is a proximal CTO. We insert, this is pilot 50 wire, so we insert the wire and we try to insert the microcatheter. Then because the tip is not that soft, you see the fine cross jumped. It happens sometimes. In this situation, I think it's better to use Corsair. You see Corsair is coming, and slowly, you see it's take this curve easily. So proximal circ occlusion, I think Corsair may help you. Fine cross may help you. So this is another example. You see, normally we don't do tip injection these days because we don't need to do it. If we cross the CTO and if we have blood from the catheter, it means that we are in the true lumen. We don't need to inject anything. But in some situation, it's better to inject. For example, here you see there is a LED CTO with a huge diagonal at the distal cap. So we have bifurcation-related CTO here. This is important because if you work from antegrade or retrograde, we should take care of this side branch, which is could be important one. This is another view. You see, it's not a long one, a short CTO, but there is a big diagonal. That's the difficulty of this case. And this is Miracle 6. Now I am almost touching the cap, and now the Miracle tried to puncture the distal cap. And then, as you see, it just captured and went somewhere. I think this is side branch. So this went to diagonal. I confirmed that, yes, this is diagonal. So what I have to do, can I work over this wire? That's the question. Or I have to do another puncture to go LAD. What I do, I insert my Corsair and I give injection. As you see here, when I give injection, contrast also fill LAD. It means that there is a common lumen at the proximal. So I puncture at the right side. It means that I can use this wire to treat this CTO. This is after implantation of one stand. So how about double lumen catheter? Where can we use it? I will show you some examples. This is another LAD occlusion. This is a proximal occlusion. There is a side branch. As you can imagine, it will be a little hard to puncture this proximal cap because it's so proximal and there is side branch. So, and this is Corsair, and again I have here Miracle, and I try to puncture it, but it's the Guidewires slip either septals or other branch. So how can we solve this problem? I have to have, stabilize my wire. In that time, I use twin pass, as you see here. I park my wire, the first workhorse wire, into septal, and I send twin pass over that wire. But I have another hole at the proximal. There is a 2 marker here. The proximal hole is just above this marker, 1 or 2 millimeter above. So this is also now Miracle, but I have very stable position now. So then, as you see, I was able to penetrate the proximal cap with this help. And after puncturing proximal cap, wire goes easily. And I feel that I am in the true lumen, but of course we have to show that. And you see, we are in the true lumen. This is after, This is another case. It's long LAD occlusion. There is nice collateral. First, I try to open this artery from the antegrade, and I insist that I did parallel wire, but I failed. So I thought it's better to use that nice collateral, and I insert Sion. As you see here, it went easily to proximal, to distal of the CTO, and turned to LAD. And I wire it, I use RG wire, and I did dilatation, pre-dilatation, as you see here. But the point is, my septals just came into the distal of the CTO. It means that I cannot work with this wire. This is RG wire, but I cannot work because it just go to after end of the CTO, it just goes to septal. So I have to have another wire to go LAD. In that time, as you see here, I insert twin pass again over the RG wire. Now I'm in the septal. So in the another over the wire lumen, I will send. You see that now I have to work with wire which goes to LAD. You see, I cannot work on this septal wire. So I'll send a soft wire to LAD, as you see here, with help of twin pass. If I don't have twin pass here, it will be very difficult to come from the proximal to distal, because I did, that part was CTO, I did many predilatation, I had many dissection there. It's almost impossible to follow that route. I could go easily under intima. So this is after implantation of 3 absorbs in this patient. You see the result is not bad. Another, I think, important example is for double lumen catheter. Again, is LAD the diagonal. It looks like there is a macro channel, but it's not a macro channel. So here I use XT wire first with fine cross, and I'm very close to cap, proximal cap, and I try to puncture somewhere here. And I change my catheter to Miracle 6 here. And somehow, yes, I managed to insert my wire into the side branch now. So, but now I have a side branch, but I have to have the LAD. How can I get it? So again, I insert double lumen catheter. So I cross all the CTO part, and just at the bifurcation part, I insert my wire into. But now I'm using CTO wire because I am not sure where am I. I wasn't at the nice point. I couldn't puncture at the distal cap. I was in the side branch, but through the subintimal arena. So what I did here, I put my twin pass to puncture again proximal cap with Miracle 6. And this is after 2 absorb implantation in this case. And 1 bare metal stent to side branch. Where can we use tornus? Yes, sometimes we need that. As you see here, we have a OM occlusion, subtotal occlusion, but it's very calcified. We were able to insert XT there easily, but I cannot insert any balloons, any CTO balloons. So what I had to do, I will insert tornus catheter with torquing on it. You see it goes nicely and smoothly. And after that, I did dilatation and I put my stent. So how about snares? I will show you 2 examples. You see there is very long RCA occlusion. I think it's better to do this case from the primary retrogradely, because too long and there is distal bifurcation. It's better to save this side branch. So we did it from the retrograde with IVUS. We did IVUS guided reverse card. But then we couldn't insert our wire into the guiding somehow. So what we will do, what we have to do is the snare, the wire. We just insert our wire into the aorta and we snare it with guiding. But this wire, we change the wire to RG wire. Okay, we don't want to snare stiff wires because it's not easy to release them later. So we insert wires and catheter and micro, and then we insert RG wire. Now you see the snare catheter captured the RG wire, and we take into the right Judkins, and we pull the snare, and we also insert. You see the micro catheter. We insert the RG wire into the hole. So this is after implantation of. Actually, we did bifurcation here. We had to do it. I think we implant 4 stent here. This is last example of mine. I think without snare, this definitely cannot be done. As you see here, there is a flash occlusion of RCA. We have no any stop anything. We cannot sit the right coronary. There is a wall there. And we did it, of course, retrogradely. And you see there is a short occlusion. And we punctured this it was so hard, we punctured this by Miracle 12. And after we were in aorta, I think there is only one way to have this wire and to finish the case by snare. And we did it, and we implanted 1 stent. Thank you very much. This is end of my